Please sit down, everyone. Andrew, you. So, my name's John Saville. I'm fortunate enough to be head of the College of Medicine and Veterinary Medicine. The principal has been at a court meeting all afternoon and just rang me to say he's on his way, but thinks we should get this over with as quickly as possible. And I was inclined to agree with him. So the agreement was that I would start. And as you can see, it took an awful long time for all of Andrew's colleagues to file in. People have come as far as Dave Burt from the Roslin Institute, David Argyle from the Dick Vet. So that gives you a marker of how high in esteem Andrew is held, that so many fellow professors have come to hear his inaugural lecture. For someone who went to the University of Glasgow, he's actually done extremely well. But before we start to celebrate his achievements, such as they are, I'd just like to welcome school students from Boroughmuir High, Craigmount High, Curry Community High, Dunbar Grammar, Gracemount High, Inverarmond Community High, Knox Academy, Leith Academy, Ross High, St David's Roman Catholic High, St Thomas of Aquin's Roman Catholic High, the Royal High School, Trinity Academy, Tynecastle High and Wallace High. So welcome to hopefully intending medical students. And I bet you your family's pretty nervous, Andrew. If I were them, I would be. So welcome to Elspeth, Andrew's wife, his mother, Beryl, his father, David, and wife, Audrey, his daughter, Zoe. I note that son, Johnny, has found an alternative gig this evening. Is that right? Yes. And Mr. Stewart and Mrs. Alison Riddle, his brother-in-law and wife. So welcome to everyone on this occasion. It's a very special inaugural lecture because Andrew is the Professor of Medicine. He's also setting up and directing the Usher Institute of Population Health and Informatics. He's Vice Principal Data Science in the university, and he's currently serving Scottish Government as Chief Scientist Health. He's got a very distinguished career, some of which I'm sure we're going to hear about. He's earned over 32 million in grants. He's got an H-index of 61. He's got 19,000 plus citations. He's a very distinguished researcher and clinician. And he's going to tell us about medicine in the information age. So over to you, Andrew.
Thank you, John. So I feel enormously privileged to be given the opportunity to be the chair of medicine at this remarkable institution. And it's an exciting time for higher education and scholarship, and indeed for Scotland. So I've been here 10 months now, and I've greatly enjoyed working with talented, experienced and dedicated colleagues. And I think there's a real opportunity to advance Edinburgh's preeminent global position in research, innovation and scholarship. As John said, I'm also privileged to be Chief Scientist for Health for the Scottish Government. And I was reflecting, I've spent 27 years of my professional life looking at medicine in the information age. And some would argue that healthcare is the last major industry not to be transformed by the information age. So I'm going to try and convince you over the next 45 minutes that it's absolutely vital that we address that challenge now. And it's not only about the quality of care that we're going to deliver for patients and populations, it's also about the sustainability of healthcare systems internationally. You know, our friends in America spend 20% of their GDP on healthcare. It's not sustainable. Health systems are characterized by waste, variation, and harm. And only if we use data will we improve that. I actually said that recently, that healthcare is the last major industry not to be transformed by the information age in Brussels, and a German put his hand up at the back and said, "No, you're wrong. Shipping hasn't been." But I didn't think we were in very good company. So, But before that, I thought I should look back at the origins of the chair of medicine. It's quite remarkable. It goes back to a chap called Sir Robert Sibbald. So he was educated in Edinburgh, then did the tour of Europe to Leiden, Paris, and got his MD in Angers. And he was not idle. He established the Royal Botanic Garden. Initially it was down at Holyrood House. He then established the Royal College of Physicians. He was appointed the Geographer Royal, and he described the blue whales scientifically. He was clearly a data scientist, I thought. He's even got a plant named after him, the creeping Sibbaldea. So I was thinking the creeping Savilia was also a plant we could aspire to. So what I'm going to do is talk about my last 27 years, how I've learnt from caring and getting to know people with diabetes. And from that education, what I think in Scotland we have is an opportunity to gear the entire country up for not only quality healthcare and research, and use data science as a catalyst for change. I would argue that with big data goes big responsibilities, but I would pose the question, can we make Scotland a health science nation, which is known globally for the quality of its health science? Currently, life sciences and health sciences are not one of Scotland's 5 major industries. And I think we have an opportunity to actually gear up and make Scotland known for not only for the quality of its healthcare, but for its science and innovation. To do that, I would argue we need to see a convergence of care with research. Before we do that, I want to take you back to the birth of the NHS, because all my research has had its roots within the NHS, and I think it's a cause for celebration. Here's Nye Bevan in Trafford General Hospital, and he said, it's quite the most ambitious adventure in the care of national health any country has seen. And it is, it's a remarkable institution. It's outlasted 14 prime ministers. Sometimes I think this is Mrs. Thatcher in the bed listening very intently to Mr. Bevan. So that was in 1948. The NHS is 67 years old. Now in the same year, something quite special on a much smaller scale was happening in this place. Does anyone know where this is? There's a clue, John. Framingham. So this is Framingham Town Hall. Now Framingham is a small town. It's about 40 miles due west of Boston in Massachusetts. And it was in 1948 when the town decided to do something really special. It was only 5,000 residents. So it's about the size of North Berwick, okay? So what they did is the residents subscribed to regular health checks. There are now 3 generations of participants, and it's a truly iconic study with over 2,500 publications. And I would argue it's one of the first examples where citizens have come together with scientists and healthcare providers to do something really special. So what did they do? They performed a series of very precise clinical measurements and defined or coined the phrase of risk factors, high blood pressure, smoking, cholesterol, and diabetes, and how those measurements link to future events which are important for patients, whether it's a heart attack or a stroke. And Claude Lafont, when he was president of the NIH, suggested Framingham has resulted in an average of 5 extra years of life, which is quite a remarkable thought. If you go to your GP and you don't have heart disease and he taps your cholesterol into the computer to give you an estimated risk, a lot of those original quadratic equations are derived from 5,000 people in Framingham. So it's quite remarkable. And if one logs on to the Framingham Civic website, they, with classical American modesty, suggest we are the town that changed America's heart. And indeed, it shows you what patients, populations, scientists, and healthcare providers can deliver at scale. However, we're on a new horizon. 2003, we elucidated the first single human genome. Martin Bobrow, former governor of the Wellcome Trust, very eloquently suggests it's like reaching the top of a mountain pass. In front of you, a fertile plain rich with new ideas, new methods, new techniques, new concepts for understanding the complexity of human biology of health and disease. And many of my professors here today are building superb scientific endeavors on the back of the Human Genome Project. So I think that's a great quote. I thought it could have been improved if he'd said, and data science is fundamental to the success of this revolution in science. So I've just said that. So what is the challenge? It's one of chronic disease, and this is really what's challenging health systems internationally. And my world is diabetes, so just a little narrative on diabetes. This was 1922, before the discovery of diabetes by Banting, Best, Collip, the biochemist, and MacLeod, who got the Nobel Prize, one of 5 Scottish Nobel laureates. And this is child B 3 months later. It's very dramatic imagery. Before this picture, this child would have expected to live 2 years at most. So it shows you the images. The most famous patient first to receive insulin was Elizabeth Hughes, who said rather poetically, to think that I'll be leading a normal, healthy existence is beyond all comprehension. Oh, it is simply too wonderful for words, this stuff. This is almost poetic. She died at the age of 74 from a heart attack. I estimate she gave herself about 25,000 insulin injections using technology such as this. So this is an insulin gun. Load the insulin here, pull the trigger, and it was plunged into the subcutaneous tissues. They are still on the formulary in Glasgow. Was it the end of diabetes? No, it wasn't. It was far. Solved by insulin. Insulin marked the end of one era in diabetes management, not the end of diabetes. And diabetes is a great caricature for the challenge of chronic disease. Great examples from the South Pacific. Has anyone been to Nauru? I've been to Nauru. It's a fascinating case study. Small population, about Morningside. In 1968, it became the second richest country in the world per capita because they had very high-grade phosphate. And they mined it, and they became very, very, very wealthy. And they underwent coca colonization. They imported fast food, a very sedentary lifestyle. They bought fast cars, Ferraris, Maseratis, Mercedes. It intrigues me because there's only one road around the island, as you can see. But the diabetes prevalence went up from 0% to 45%. And now they're on the verge of bankruptcy because they've run out of phosphate and they have spiraling healthcare costs. So it's a narrative which could concern us, because if we now look globally, in the next 20 years, or current 20 years, we're seeing the numbers of people living with type 2 diabetes increasing by 236 million to an estimated 485 million in 10 years' time. And I saw this for myself when I first went with Jim Petrie in 2000 to Sri Lanka, where in a room such as this, about 25% of you would be living with diabetes. So I also learnt a little bit of geography, because I thought this was Sri Lanka before I left, but I landed here. So let's now move to Scotland. And the thing about Scotland is we have fantastic data. So I'm great to see Tim Ellis today, our Registrar General, because these are his data. And if you look at the changing demography over the years, Scotland is changing rapidly. So we have much fewer people in the younger years to cater for the aging population. And I'm sorry, Professoriat, but gazing in front of me, I think you're all up here. So, and this is the challenge, because this is why there are pensions issues. This is why austerity is a real challenge, because we need to get a working population. But associated with that is a rise of chronic disease. And again, Scottish data from about 2 million people. This was in the Lancet a couple of years ago. We asked a very simple question. How many people, for example, at the age of 70 have no chronic diseases or one chronic disease? It's actually a minority. Most people are living with 2, 3, 4, 5, 6, 7, up to 15 chronic diseases. And this is the world we live in. And I would subscribe to the view that this presents a fundamental challenge to the single disease focus that pervades medicine today. Because in In Dundee, I did my diabetes clinic on a Friday. I often saw patients who'd seen the ophthalmologist on a Monday, the vascular surgeon on a Tuesday, the cardiologist on a Wednesday, the renal physician on Thursday. We need data science to actually streamline that process. Of course, the other jeopardy which we face is that of the national debt. Does anyone know what the national debt is? David, you're good with money. Trillions, you're right. It's 1.56 trillion pounds, which is 84% of our GDP. So we need to think about how the economy is going to be increased. And we're all too familiar with the current nadir in Scottish public funding. So these are challenges facing us. So how are we responding to this challenge? This was from the Financial Times 3 hours ago. I'm afraid hopes for breakthrough and Greece deal fade. This will impact upon us all. So I thought, who do we need? We need Atlas who said, believe me, carrying the world was much easier. Because this will impact upon the European economy. And being in Scotland, I thought of who could I think of a Scottish mythical character to summarize this? So do you remember this guy? No. However, I think our thesis is that across the UK, and particularly in Scotland, we can deliver better quality care at reduced costs. We can translate excellence in biology and basic science through clinical trials and innovation to world-class patient care. And I believe that if we harness data science and informatics and interdisciplinarity, it will smooth that path and make us very successful. And I think that is a real prize for us all. And it wasn't, this isn't my idea, this is David Cooksey who outlined the roles of informatics in translational medicine. And he argues that across that pathway of discovery, innovation, and patient benefit, we were slow to actually harness informatics tools, methodologies that most other industries have achieved. So that's the opportunity. And just to show, you can't read that, but just to show that things do change rapidly. This is a slide from the RAND Corporation, very respected. So this was in 1954, and it says, scientists from the RAND have created this model to illustrate how a home computer would look like in 2004. However, the needed technology will not be economically feasible for the average home. So that's what they said. But look what we carry around in our pockets. So this is illustrative of the speed of change. So what I want to do is just talk about each of those spans of the bridge to illustrate a few opportunities. And let's start with patient care. This is the new official map of Scotland. I hope you like it. We in Scotland spend £12 billion on healthcare, but I think we're fortunate that we can collaborate at scale to actually look at diseases and wellness across the entire population. And to do that, one needs to collaborate at scale. And one of the things we inherited back in the 70s was a unique patient identifier to achieve that. So this isn't rocket science, but it works very well. So everyone in the room will have a so-called Community Health Index number. So this is my number. It was a big year for me last year. And this is appended to every episode of healthcare, regardless of where it takes place. And we have to credit this chap, who's still alive, Dr. Ronnie Graham, for implementing this in Scotland. And this is his original publication. It's the best pound we've ever spent in the NHS. Because he said, if we implement this, it will transform services and research, leading to a more integrated approach to healthcare. And he was right. He was right. Because sadly, this is still the healthcare system that many of our patients have to negotiate. It's fragmented, it's siloed, the data don't follow the patient in real time. We have the opportunity, and I have to credit Dennis McDevitt and Tom MacDonald for supporting me in my early days to actually link this through in a systematic way, to give a picture of the journey of care of an individual. So just to show you 3 quick examples of that, emergency care summary. So I'm glad Libby Morris is here today because she's pioneered this work. So if you are admitted today to any of the 38 hospitals in Scotland, The admitting physician can see your electronic health record derived from your GP. 3.5 million accesses per year, changes management in 20%. We've done the same for nationwide radiology. So Steve Pavis has led on this, and I'm delighted that Joanna Wardlaw is leading the charge on looking at how we can take this unique international archive of 17 million studies of MRIs, ultrasounds, PET-CTs into a research environment. And my example, we were fortunate to define a chronic disease management plan for the nation. I chaired the Scottish Diabetes Group, followed by Donald Pearson and Johnny McKnight, who's here. Really got to acknowledge the work of Jim Petrie from Aberdeen, who was a real leader in this space. But we defined a national plan, a national data set, national standards, and national measurement. And it works very well. And we were very fortunate to be able to take early evidence from Tayside. This is Ray Newton, who I think is here tonight, which is terrific. This is me in my early days, to measure diabetes on a population level. Sounds straightforward, but in its day, it had never been done. So this was our early publication to show how we characterized diabetes in a small population. And for the last 15 years, we've spun that out to the whole of Scotland. So we've got the best data in the world for an entire nation's population with diabetes. Johnny McKnight published recently on 230 people living with diabetes, and we update this nightly from every general practice and every hospital. So it's common sense. It looks something like this. It's a wonderful clinical tool, and I think the reason it got traction is that we tried to embed quality of annotation into the data collection from day one. And we actually employed data scientists to actually ensure data quality. I think this was an important thing. This is slightly tongue-in-cheek, but Richie on the left, he came running up to me about 10 years ago. He says, "Andrew, we've had a few miracles in Dundee." I said, "What's going on, Richie?" He said, "Well, Andrew," he says, "I found 10 patients walking around Dundee who, according to the NHS, are dead." He says, what are we going to do? So being an academic, I said, "Well, Richie, clearly we'll publish that." So if you look very carefully, the life after death range is 1 to 4 years, and the resurrection rate is 0.092. But there's a huge opportunity if we enhance data quality. And it's a fantastic clinical tool. So Johnny will acknowledge that in our clinic, we can see all the data in real time, what the podiatrist has done, the specialist nurse has done, the digital images in real time, and patients love it, and they're now accessing their data. The good news is, since 2007, for 95% of the population, we've been recording key biomedical markers. And what we've also published on is improved clinical outcomes in terms of amputation, and this is risk of blindness due to diabetic retinopathy. And it's my hope that in my professional lifetime in Scotland, we'll see a year where there are no cases of blindness due to diabetes. I think that's tractable. And I would like Scotland to be the first country that reports that. And Helen Cahoon and colleagues published on life expectancy. We're still losing about 11 years in men and 12 years in women, but it's a lot better than the United States. So that's the routine data, but one could also use the same data for so-called discovery science. And here's a little example of that, working with two friends from the protein phosphorylation unit in Dundee, Dario and Graham Hardy. Because Dario and I had a coffee one day, and he said that he just discovered that the upstream regulator of AMP-activated kinase is a protein kinase called LKB1. So this was in the cancer field. And Graham had recently reported that metformin, the most commonly used diabetes drug in the world, activates LKB1. So we asked the question, if we use metformin in diabetes, does it actually reduce the risk of cancer? And being very open-minded, I said, "Rubbish, Dario. We use metformin to lower blood sugar." But actually, when we went to the population, we saw about a 30% reduction in cancer. These are observational data, but then we took it back to the lab in a model, a P10 tumor suppressor model, and this is the tumor formation rate in the controls, and that was metformin, and that's fenformin, a more potent agonist of AMPK. And that led to new discovery science. And as of today, there are 237 international trials of metformin in cancer based on that original observation on the US website. It also allows us to look at social science. What's it like living with chronic disease? This is Mrs. Jones showing us her diabetic life, and it's not easy. So this is her life. She takes 9 tablets for diabetes. She's got high cholesterol. She takes a simvastatin. She's got high blood pressure, so she takes a triage of medications there. She's had a stroke. She takes aspirin. She's got a little bit of angina. She's got mononitrate. This is everyday life. She's on thyroxine. She takes amitriptyline, probably because she's on so many tablets, I thought. But it's a challenge. So we can also use routine data to look at these challenges. So these are some early studies where we looked at concordance with medication. If you had diabetes for 10 years, would you take 22 tablets a day? I think it's normal behavior. The median uptake on monotherapy is about 300 days in every 365. And when you go to multiple oral therapies, it goes down to about 4 months in a year. And I think this is normal behavior. And we, the medical profession, totally misjudge what is feasible and acceptable. So we can look at concordance. I'm a great believer in diabetes fatigue. It's not as easy as we think. So let's try and keep it as simple as possible and support and empower patients. So collect data once, use it often. So I think this is clearly the future of diabetes care. John Saville was worried that was a suppository. But this very simple model is scalable. And Mark Walport, he published in the Times a few years ago, joined up healthcare will save money and lives. And I think it's right. And he suggested if you live in Dundee and suffer from diabetes, you've recently taken part in a medical revolution. But this isn't a medical revolution. This should be standard care for everyone living with chronic disease, cancer, respiratory. Because we are capable of delivering it in Scotland. It's frustrating how untractable it appears to be at times. So that's the patient care end of the equation. What about the research domains, this convergence of care with research? And I've been very privileged to take over from John as Chief Scientist at the Scottish Government. This is him pretending how to use a microscope. But if Scotland is going to compete, we've got to collaborate in where it makes sense to do so. So the CSO was 40 last year, and what the main message was this convergence with care and research. So the Chief Scientist's office is 40 years old. And sometimes when you live through medicine, you don't think things move, but actually they do move. So what I did was say, what did we not? If I'd been the first Chief Scientist, so Andrew Watt Kay, what would he not have had in 1974? First of all, the Glasgow Coma Scale, used globally. MRI had its origins in Aberdeen, was not invented until 1977. Transformed medicine. Statins didn't come along to 1986. So things do change in medicine. This one intrigued me. Laparoscopic surgery didn't come along to 1990. I love this slide because it explains clearly why you can never find a surgeon in a hospital. It's John Forsyth here. You see, I told you. And in terms of public health, the smoking ban in public places. So things do move, and Scotland's made major contributions to all those discoveries. So what our manifesto says, we want to build on our great universities and great science. We want to collaborate systematically in our tripartite mission of education, research, and care delivery. Collect data once and use it often. Look at the governance. collaborative arrangements with industry across all its vertical dimensions, and position Scotland as a single research site when it makes sense to do so. I've got great colleagues nationally. Mike Stevens is here tonight. He's the head of the CSO, plus our R&D directors nationally. And where it makes sense to, we try to harmonise activity, whether it's clinical research facilities, biorepositories, project management, research imaging, and data. I was in China recently. They have 110 million people living with diabetes in China. And that is scale. So for us to compete, we've got to be, it has to be around excellence, knowledge, and efficiency. So that's the script here. So a few case studies. Is it working? Is it working? So clinical trials, because no trials, no new treatment. So clinical trials are our final common path. And there's some great examples of us being able to use data to stratify eligibility and enrollment to trials. It's been associated with significant income generation, and I'm glad Brian McKinstry's here with his tie on tonight. He's leading with Colin Palmer, a national register of Scots willing to participate in clinical trials. Scotland, the UK used to do 10% of phase 3 studies about 12 years ago. We hemorrhaged down to less than 2%, but what we're now seeing, this is one of Mike's slides, is Scotland actually being the top global recruiter, first patient in. This means that we're able to re-energize the clinical trial process, and that creates jobs. So it's about an £18 million business in this very precise phase 3 environment a year, which is good. What about evaluation of policy? So these are routine data looking at government policy. Evidence-based policy would be a good thing. So let's look at the right panel. So after the smoking ban, legitimately we could ask, did it work? So what Jill Pell and colleagues did was use routine data. These are hospitalizations for asthma in 5-year-old children. Okay, so before the ban, a 5.2% increase. After the ban, an 18% decrease. So a clear benefit, public health benefit. I was in India about 4 years ago, where they initiated one of the largest smoking bans in the planet, 1.3 billion. I was asking them about their policy evolution, and they said, well, we use Scottish data, which is quite a nice thought in terms of being able to demonstrate the impact of what we do. Diabetic retinopathy, we arbitrarily say, if you've got diabetes, be screened annually to prevent blindness. But it's very arbitrary. So what we were able to do, this is a busy slide, but ask, can we stratify to increase the screening interval? Pure and simply by using phenotypic information, clinical data that we collect. And the bottom line is, if you've got type 2 diabetes, which is common, and 2 examinations showing no visible retinopathy, we can safely offer 2-yearly screening because your risk is so low, which is important because one can screen 44% fewer people. So this is stratification of patient pathways using routine data, which we should be doing all of the time. What about national programs? I'm delighted the university hosts 2 of the innovation centres, Dave Robertson, Leslie at Yellowlees, Bruce Nelson, and Liz Elliott, Digital Health Institute, and where's the other one? Data Lab in the corner there. But again, I would argue these will just become small programs of activity unless we weave them together across the patch. And we're trying to do that. I'm delighted we're collaborating with the Scottish Funding Council, and they've put £1 million into a Transforming Cancer Care in Scotland Challenge Fund. In 2 weeks' time, we're getting all the innovation centres into a room to collaborate to try and come up with innovative solutions. What about international collaborations? And this comes back to the Enlightenment. If we're going to have a 21st century Enlightenment, we need an impact on the world. So a thesis that I had a few years ago, that we could take this Scottish health science and quality package of education, skills, informatics and research and support other nations internationally. So this, I thought, where will we go? I chose another small oil-rich nation of Kuwait, because the prevalence of diabetes there it's about 25% now, so it's very high. When I first went, I saw a 24-year-old man losing his leg, an amputation from type 2 diabetes. So it's just ravaging society. And we put in a package of clinical skills, education, informatics at scale. And recently we graduated 200 MSc students, which is good. And we also, working with my other favourite Sybil, David Sybil Ridia, put a Kuwait health network in place. So we took Scottish business to Kuwait, putting a private cloud-based architecture in, and created a Kuwait health network, a bit like the Scottish Diabetes Network, as you can see. And an idea I think we have, and opportunities, can we expand this to internationally? So colleagues in Edinburgh, Jonathan Seckel and colleagues are exploring a collaboration with the Strategic Alliance for Medical and Healthcare Industry of China. 17 member organisations. They own 1,000 hospitals. Can you believe that? 1,000 hospitals. In Scotland, we have 38. So this is healthcare at its most challenging, and I would argue that there's an opportunity to put in packages of education. So we sent our team out to China last week. This is Dave Robertson and Liz Elliott, but they're always under the careful eye of Andrew Mauris. I hope you, I hope you like that. And lastly, what about genetics and personalised medicine? Because I talked about the Human Genome Project. And I think this is where we have an outstanding opportunity in Edinburgh, because it's the same population model. I've talked about epidemiology and trials and clinical care. Can we deeply phenotype reliably and longitudinally to really understand common complex disease? That's the opportunity we have, and the United States will struggle to do that because of the fragmentation of their health systems. Oops. And I've been very privileged to work with many colleagues, including David Porteous and Shona. For example, we established Generation Scotland, and that is like a fine wine. It's turning into an outstanding international family-based resource for cognitive function with Ian Deary and mental health research. So it's a small but very boutique study which will be a major driver of discovery science. And just to show how this works, population pharmacogenetics. So this is about understanding who is going to respond to what drug. So again, we used metformin. We used routine data to define exposure, therapeutic response, plus we performed genetics. So this is called a genome-wide scan across about 4,000 patients with metformin. And we discovered new biology. Again, ATM, which regulates cell cycling in cancer, but to discover new biology from routine data. To run that study de novo would have probably cost £100 million. So the value of routine data. And this is moving very, very quickly. As I suggested, the human genome was first described in 2003. So this is the White House. This is Bill Clinton, Francis Collins of the NIH, Craig Ventnor, who was Celera Diagnostics, announcing that we'd sequenced one person's genome. I should say Tony Blair was also there, but I cut him out. So, but why did they celebrate it? Because it took 300 scientists 15 years and $3 billion. We can now do it in about a day for $1,000. It's just phenomenal. And I must say, I'm very privileged. I'm very privileged to be chairing Edinburgh Genomics because within the university, we've got the largest university-based genomic capability in the UK, one of the largest in the world. And to bring it all under one umbrella is going to create an outstanding international powerhouse of genomics science. And I must say, it's a very easy committee to chair because if you look along the back row, we have David, and David. So you immediately have a quorum. It's great. And I'm delighted that we've also made major collaborations with the Innovation Centre based in Glasgow, which has brought in many industry partners. So just to finish off with a few thoughts in the last 5 minutes, what are the big issues here? Because there are some huge issues here. The first one is that this is a tidal wave of data. We're defining disease now not based on symptoms or biochemistry, but by molecular phenotype. And it's heterogeneous data sources. So the future of medicine really looks, I like that slide, I'll show it to you again. There we go. It's becoming more complex. So I think that's going to be the first challenge. And I've only touched on the data within the privileged domain of the NHS. More data will be derived from us all. For example, Apple's new research kit, launched four months ago. It uses an iPhone to monitor Parkinsonian tremors and cardiovascular fitness. Stanford recently ran a study and they recruited 11,000 patients in a week. This is going to transform the way that we do clinical medicine and clinical research. The second big issue is maturity, digital maturity in the NHS. And this really, really troubles me because many talks from this lectern are around personalised medicine and prescriptive analytics. Here we are, up at level 8, but how mature are health systems internationally? I did some work down at UCL Partners. We're not at the 8 level, we're at the 2 level. If the health service takes 20 years to catch up, we're not going to realise the benefit of molecular medicine. So in an attempt to address that, scientifically led, we've established the PHAR Institute across the UK. So these look like 4 UKIP candidates, but they're not. There's Ian in Manchester, Ronan in Wales, Harry in UCL and myself in Scotland. £39 million investment from 10 funders. And basically we want the UK to be world leading in this. The integration of discovery science with routine data collected on a population level so that we can not only drive up quality of care but new knowledge. And these are the teams, these are our 10 key activities. We basically want to take the model we've developed in Scotland and scale it across the UK. And we've been very fortunate that across the Scottish partnership with the NHS at its heart, we've established a so-called research hotel, the PHAR Institute, which is just up the road from here at the Edinburgh Bioquarter. It's where we can breathe the same air. Computer scientists, social scientists, NHS colleagues, other academics, industry, trying to address these problems together. And I use the phrase, it's a research hotel. And people absolutely love it. It's working, particularly because, as you can see, it's free parking, which is very topical on this site. And we've done the same in London. This is the PHAR Institute on Euston Road. We've done the same in Wales and Manchester. But in Scotland, we're even a step ahead. Working with the School of Geosciences and Chris Dibben, we've co-located our Administrative Data Research Centre with Tim's support and that of Roger Halliday, who's the Chief Statistician of the Scottish Government. So in Scotland, with good governance, we've got the ability to link and use data across health and social care, linking into consented bioresources. It's an outstanding opportunity for us for a population of 5 million. The fourth big issue is this interdisciplinary issue. People often say, why did you come to Edinburgh? This is one of the main reasons I came to Edinburgh is Dave Robertson and his colleagues, Joanna and the team in the School of Informatics, because it's an outstanding opportunity. This is the ref. So in computer science, Edinburgh was the best in the UK. So in Dundee, I had quite a large team of people who helped with the health informatics, but there's only 10 of them. Here we have 1,000 people. And if even 10% of those colleagues wish to look at applied research, we've got a great opportunity. And what I'm learning from Dave and colleagues is that what we're seeing in computer science is two things. Not only huge progress in the development and impact of individual methodologies, but a confluence of these methodologies. And I think that's the opportunity in healthcare. And I think we have seen cumulative success over the last 18 months in terms of Digital Health Institute, the PHAR, all the way up to the Alan Turing Institute. So it makes Edinburgh a powerhouse, not just in Europe, but internationally, because of this blend of discovery health science plus computer science. And shown schematically, what I hope to spend the next 20 years doing is looking at medical informatics, but looking outwardly in terms of the data, whether it's personal, physical, or organizational, working with colleagues across campus, Edinburgh Genomics, PHAR Institute, close college with NHS, but learning where can we deploy these new computer science methodologies, whether it's artificial intelligence, sensing, machine learning, and working with colleagues targeting them at real medical problems, effective personalization of therapies, stratification, real-time evaluation, real-time integration. Because I think this is the future of healthcare as we know it. And an important dimension to that, I mentioned Iridia before, but what I'm delighted to see across Edinburgh is a cluster effect beginning to happen in terms of industry co-locating with scientific excellence. And one best way of helping people in terms of poor health and inequalities is give them a job. So the more economic growth and innovation we can promote, the better. And the last big issue, of course, is the most important one, is with big data goes big responsibility. We need to design our systems in Edinburgh and Scotland for transparency and trust. I would argue there's a trust in data deficit. This is a Mori survey, and there are almost daily concerns. These are some news headlines from the last week in America, in, I think that's Ireland, in Japan, and in Scotland. So unless we get the public trust and the privacy, the confidence of our citizens, we will not make the progress that we think is within our grasp, and we will squander an opportunity. I think, we're very fortunate in Edinburgh, work very closely with Graham Laurie, defining best practice, proportionate governance at scale, work very closely with Sarah Cunningham-Burley in public engagement. And what we've been able to do in Scotland is actually move that into government policy. So I was privileged to support or chair the data vision for Scotland, the data linkage strategy, and we've got a nationwide approach which we have tested with the public and appears to have public support with something I'm very proud of. We now have a single National Privacy Advisory Committee, meaning we can do nationwide studies with single scrutiny, making us efficient as a nation. So, principle. To conclude, a few reflections over the last 27 years. I've been hugely privileged to work with great people and inspirational teams, because this is team science. That's a bit of a crass phrase, but it is, because not one domain has all the skills required if we're going to deliver in this space. I think start and finish with the patient is so important, because they usually tell you the answer about what is right and what needs to be done, with a commitment to public engagement. This convergence of care, of research with care and innovation, so that we partner with industry in transparent and open ways, is going to be really important for Scotland if we're going to create an economy for which health science is internationally competitive. I would argue the time is now to bring data science into healthcare for patient and public benefit. I think we've got a great opportunity for Scotland to lead the way. And to paraphrase from the University 2025 vision, continuing the enlightenment of the 18th century to the present day, why don't we make Scotland world famous again for the medical institutions and the quality of care that we can deliver at scale? Because the future of medicine, I think, is 4P, predictive, preemptive, personalised and participatory, and it will only be made possible by genomics, accurate real-time phenotyping, informatics, analytics, plus a new social contract, so that it's perceived to be in the public good. So that's the sort of formal bit, but this is the bit of my life I really enjoy. So Zoe's here today, Elspeth's here today. Johnny's John said, Johnny's he's actually on a geography field trip in Fife. So he sent me a picture of himself at lunchtime. There we go. So, and Emma's, she's just finished her A-levels, so she's partying. Sadly, she's been partying for 3 weeks. So and Willow would have come, but sadly she's on heat, so she couldn't make it. But thank you very much. I started with a few quotes, just to finish with a couple of quotes. The road ahead for the next 50 years. So I quite like this one. The only place where success comes before work is in a dictionary. So I think that's a good one to inspire us. But then I saw it was a hairdresser who said it. So I looked to the US for some inspiration. So do you remember Dan Quayle? If we do not succeed, then we run the risk of failure. So I didn't think I could leave you there. So two quotes, one from the master, in the middle of difficulty lies opportunity, because this is really difficult stuff, because it's so interdisciplinary. But more importantly, and Zoe's a classicist, this is her favourite person, Cicero, life is nothing without friendship. So thank you to everyone who's been a great friend to me over 27 years, and I look forward to many friendships over the next 27, unless I'm sacked.
I'm Tim O'Shea, I'm the principal. I'm sorry that myself and Professor Yellowlees, the head of College of Science and Engineering, came in late. We were with our governing body, and it ran on a little bit long. But I'm glad we caught most of it. And it's just quite inspirational. For me, obviously, we all have medical circumstances and relatives with medical conditions, so that is one driver. Another driver for me is I'm a machine learner, which is an area that is fashionable again, and I got really very important here. But what for me is incredibly striking is this is hard stuff. This is very complicated stuff, because you're talking about illness, you're talking about medical practices, you're talking about data, you're talking about statistical means of treating data, you're talking about advanced computation, and you're talking about the bureaucracies that go with local government and go with the health service. And Andrew just talked about it in such an accomplished and entirely clear way, and he talked about it with humour, and he talked about this very, very important enterprise with ambition. And if there is someone who can put Scotland at the forefront, and the University of Edinburgh as part of that at the forefront of this incredibly important opportunity, it's Andrew. And so please join me in thanking him again.